what would be makes you a professional caregiver? Yeah, be on time. That's wonderful. Yes. Okay, something else. Clean uniforms always look sharp and clean.
And don't talk about yourself
In a negative
your
light.
shifts.
We're there to uplift and leave them happier than we found them.
and talk about their problems,
Yeah.
not your own.
Ask about them. They love to tell their stories and share. Absolutely. Yeah, wear your name badge. Punch in and punch out. Yes, yes, yes. We don't know that you've been to a shift if you don't punch in and out. So if a family member calls and said, my mom said no one showed up today because she doesn't remember, we have no proof. We can't say, well, they did clock in and they did clock out and they charted. You want to make sure you do your charting at the end of your shift, 5 minutes. So those are all great, great answers and things to remember. But the one we're going to hit on today is safety. Body mechanics, and good body mechanics creates safety, you know, for not only our caregivers, but for our clients as well. And so let's see. Along with safety, closed-toed shoes, none of this stuff. So, yeah, we want you to have good footing. You know, we want your feet to be stable and protected, you know, and not slide around. Our caregivers of the month, and I don't believe either one of them are here, Sydney Allen and Zoe Hales. And so they did a little write-up. If you go on your email or whatever, then you can read them there. And then Vicki Luke is our caregiver recorder. So we're really pleased that we have, all of you do. You all step up and go the second mile, and we appreciate that. So without further ado, we will have Katie Patton come up. She works with Canyon Home Health and Hospice, and she's going to talk to us about body mechanics and so on and so forth. So take it away.
So I'm a physical therapist. Like I said, I work in home health and hospice, so I'm kind of in the same setting all of you are in the patient's home. And you know, we work with a variety of levels of, you know, ability in the home. Some people are pretty independent. I think that you work with, aren't they? I mean, maybe not cognitively, but like physically, but all the way down to, it sounds like
We do transfers and
and mobility and things like that. So, and how long did you want me to, whatever?
Well, we usually like to end about 10 to 1. So
Okay,
that they can have their delicious dessert.
I probably won't be that long. We're gonna get out early today. I don't know that I have that much to share, but so I was asking to talk about body mechanics and like transfers, things like that, safer in the home when we're working with the client. So y'all have this handout. Sorry, it's kind of dark because I just took a picture of it with my phone and texted it that way rather than scanning it because I was being lazy. But I didn't want to walk down to my basement to scan it. So some basic things. First of all, tell me about some of your think of like one client you have right now and talk to me about what level they're at. Are they independent? Do you have to help them with their transfers? Do you have to like help them get in and out of bed? Just watch, stand and watch?
Wow.
Somebody does. I know you're not quiet yet, but maybe you help one.
Well, the one that I shadowed, not fully transferring. But it's just keep an eye on them.
Kind of stand by.
Yeah, stand by.
Okay. Anyone else?
Basically blind, and I just have to
basically her eyes.
So she needs just more cues and things like
She's
that.
very independent, but it's basically her eyes looking around.
Do you have clients that you have to like actually lift?
We
Do
do.
a lot of like.
And, you know, this group here may not be in this category, but we have a lot of caregivers that have back issues. And so they just say, I can't do any lifting, you know, we want to protect their backs, but there may be some back issues that if they were using good body mechanics, that they could handle it. I don't know.
All right, so basic things with body mechanics. How are we supposed to, like, tell me some of the things you know about body mechanics. What are we supposed to do when we're moving or helping?
One, let them do as much of the lifting as they can, because a lot of times, like when I tell people go from like the bed to the wheelchair or something, they can use their own hands and do it, but then I should be using my knees and not my back. I should be squatting down with my back straight and then kind of like, I put my knees with them, we stand up together, I scoot, and then I go like, I don't know if that's
Perfect. No, I like what you first said it very first of that
Okay.
too, was like, have them do as much as they can. That is one thing I see a lot in when I'm like in assisted livings and where I see aides helping the residents there. They want to just do as much as they can for the patient, which is fine, except for from a physical therapist standpoint, we're all about independence. That's our goal, is to get them as independent as possible. And so we're always like trying to get them to do what they can do. Plus it's easier for you. I mean, it takes a little longer sometimes to let them do what they need to do. It's not as fast, but it's less work for you, I mean, physically. And so I have that on there. Let the patient do as much as they can. Your goal, have them do as much of the work so you can do as little as possible. Now that sounds really bad, but really when I'm trying to work with a patient, that is my goal. I want to do as little as I have to physically. It saves me and it helps them to be more independent. So think about ways that you can do that. What else? Body mechanics wise, do you know? What kind of things do you know about body mechanics that you should be doing? You should know all of it. I think you're there, you can learn it all again. So some of the things are listed here. The first thing it says, no bending or twisting. Okay, these are good principles for your back. Use your legs, not your back. I'm sure you've all heard that before. So if you're going to help somebody who's sitting on a chair, you're not going to do this, right? You're going to come in and you're going to use your legs to help them if they need that much support. So use your legs, not your back. Don't bend. And then you kind of hit on this, how you kind of use your knees and kind of, and you made that little motion. When you're helping somebody from one surface to another, you're not going to like twist, okay? You're going to help them and then you're going to take little steps around. Twisting at the same time you bend is a sure recipe to blow a disc in your back. Like it's bad. Bending's bad, twisting's bad together. Really, really bad, so just don't do it. Okay. Make sure your equipment is ready. Do many of your clients have like wheelchairs that they use? Wheelchairs, or are they mostly walkers? Lots of walkers. Okay, so walkers, wheelchairs. So just make sure that if they're gonna stand up and they need their walker, that is ready. So then they're not standing up and then you're like, oh shoot, I need to pull that over. Or if they're going to a wheelchair, that they have their brakes set and it's in the right position. How many do any of you have people that have wheelchairs, that use wheelchairs in their home? Yeah, a few. Okay. It's probably not as common, I would think, because they're still in their homes.
But a lot of times they use them out.
To go out, that's true.
Yeah.
Okay. So arrange chairs and equipment for least distance of possible movement. And I will demonstrate, we'll go through like some demonstrations of these at the end. But if you are getting them into a wheelchair to, take them out to get in a car or whatever, have the chair right next to the surface that you're coming from. You don't want to have to like move them further than you have to. Again, it's that, well, don't do more work than you have to. Okay, right next to it. Make sure equipment is the right height if adjustable. So sometimes, wheelchairs aren't really adjustable, but if they have hospital beds that go up and down, sometimes that's nice because you can get it higher and it makes it easier for them to get out. Lower easier to get in, things like that. Remove armrests and leg rests, that's specifically for a wheelchair. And
Those two.
I'll show you how to do that. Do you all know how to remove stuff from the wheelchair?
Like a refresher.
So if you have a patient with a wheelchair and they're going from their bed, or if they're in another chair, so they're like in a chair here, and you want to get them to their wheelchair, you're gonna want to take that out of the way, because then it's not in your way. You're not gonna trip on it. You're also gonna move that one out of the way so that it's not in your way either. They also come all the way off if they're really in your way. You can put them like that. The little pegs here just go right in those holes. Super easy. And then when you flip it around, you want to make sure they lock in. But so make sure brakes are on. So everybody know how to do that. Brakes on the wheelchair. And then the armrests on most wheelchairs will either flip up or they'll come off all the way. So you can just take them off if they're in the way. And if the patient's standing all the way up to transfer, then you don't usually have to take them off. But if they're more like of a pivot transfer, then taking them off makes it a lot easier, because then you're going from a height that's pretty even to another height that's even, instead of having to lift up and over. So that, if I were transferring a person from this chair to the wheelchair, I would set it up just like this. Then you want to make sure the wheels are out of the way, so that they just have to go. I mean, if they're standing up, it's like one step and down. Okay, get the wheelchair as close as you can. If they're doing a squat, then get that out of the way, and then all they have to do is that. Super easy. Okay. Do you ever use gait belts in the home? Transfer belts? I use mine all the time, because, well, there's some liability if you don't. I learned the hard way when I've been doing this for like 20 years, and I had a client who was ambulatory. He had bilateral lower extremity amputation, but he had prosthesis on both, and he was used to just getting around, and he had a wound on one, so he wasn't wearing that one. He was like 30, super young, using his walker, just doing awesome. So we were just walking. I didn't have to touch him. I didn't have to do anything. And we walked past a room, and he recognized somebody. We were at the hospital, recognized somebody in the room. So he kept walking, but he lifted his hand to wave at them. You can't walk with one arm and one leg. It doesn't work. So he fell, and I didn't catch him because it was like so fast, and I didn't have a gate belt on him. And I got in trouble. So I learned in literally that was like, I was like 3 months out of school. So ever since then, I use a gate belt on like almost every single person, because it's because you can grab it, even if you don't have your hand on it. There's certain liability that you can say you were using a gate belt. Anyway, plus I did not learn this the hard way. One of my patients learned this the hard way. He was in a facility, and he had a stroke, so his arm was flaccid, couldn't move it, and somebody tried to help him transfer by pulling on his arm, and they tore his rotator cuff. So that's like insult to injury right there. So I always use a gate belt, because there's something good to hold on to besides an arm, which you might end up injuring your patient.
You always just carry one with you.
Yeah, I would have in my backpack. I have a backpack with like my vital signs equipment and other stuff that I use for therapy. And now a lot of COVID, the gowns and the goggles that I didn't used to carry, but I do now. Yeah, so I just always keep it with me. There's lots of different kinds. I use this one now because I disinfect it in between patients, but it's plastic. They're not super comfortable for the patient always, but you don't have to leave them on for long. Just during your transfer.
If he was wearing one of them, you probably still couldn't.
I probably would not have. Yeah. It was like just a huge fluke, but I did get kind of brained because we didn't have a gate belt on. So transfer towards the strong side. So do any of your clients ever like post surgery? Do you ever see anything like that, like hip replacements, knee replacements, that kind of thing? So if they're in home and they've had that kind of thing, or they have a weak side from a stroke, you always want them to try and transfer towards the strong side. That's going to help you if they can. So if my right side were affected and I were transferring, I'd want to go toward the left side. So that's going to be different. And then again, when you're setting up the other way, if I were here and my strong side was here, then I'd want the chair on that side. It always helps them to be able to do more independently, and it will help you have to do less. Again.
So you would set the chair next to that chair next to that.
I never do that. The only reason I would do something a little more like this is if they were complete, even then, I don't know. If I were using a sliding board, do you ever use sliding boards? Like the transfer boards? You should have brought one of those. If they can't put any weight on a leg, then sometimes, or if they've had a spinal cord injury, we use transfer boards sometimes. And those, you kind of want more of a straight. And I probably set it up like this, and the board just goes across, and then they just use that to scoot across. So make sure you know any precautions if the patient has any, like if they've had like a spinal surgery, they're not supposed to bend, they're not supposed to lift, and they're not supposed to twist. See, just good mechanics all together. But sometimes when we want to stand up, we bend like this, right? And that's a big no-no for patients who have had a spinal fusion. So you have to get them toward the edge of the chair and have them kind of stand straight up. Okay. And they should know that if they've been taught well, but sometimes they forget. So good for you to know that as well. Hips sometimes will have where they can't bend, just the same thing. And pacemakers, anybody have a patient with a pacemaker that you know of? Okay, if they came right out of surgery, they're not supposed to lift their left arm above 90 degrees. Just so you know, it can pull the leads out that they've put in. So you do
That's just
that.
for a certain amount of time, or is that
Yeah.
for like ever?
No, it's for like
Okay.
12 weeks, and then it's
Okay.
okay after that. But yeah, so you can, anyway, if they've had surgeries or things like that, it's always good to know if there's certain things they're not supposed to do, because you don't want to mess with this. All right, so types of transfers, sit to stand transfers. Sometimes patients get like stuck in their chair. Like they just can't get out. Have you had that happen? They're like pushing. So these are things I always teach every patient when they're transferring, and they can do it from any surface. They can do it from their bed, they can do it from a wheelchair, they can do it from a couch, they can do it. And no matter what surface they're on, it's going to make it easier. It might not make it so they can do it themselves, but it will make it a lot easier for them. So the first thing is, actually, I want you all to try this. Sit as far back in your chair as you can. And try and stand up. Okay. So some of you popped right up. Some of you kind of stumbled a little. Okay, sit back down. Now, scoot forward to the front of your chair, to the very edge. And then try it again. Is that easier? Okay, so that will always make it easier. That's the first thing. So if you're having somebody who's having a hard time, especially like couches are the worst. They like get like sucked in and they're like being absorbed by the couch. And they just can't get up, and then you're having to like heft them out, right? So if you can get them to scoot forward, it's gonna make it so much easier to help them get out. So that's the first thing, scoot forward in the chair. If they can get forward, that's awesome. A lot of people get afraid. They like scoot like this and they're like, I am forward. You're like, no. We're talking like here, not here. So the further forward you can get them, the better. Another thing that will happen when they scoot forward is they'll put their feet out here. So you're basically in the same position as you were back there. So scoot forward, but keep your feet underneath you. So scoot forward, feet back, and then we always say nose over toes. So you put your nose forward, and if there's something to push from, even if it's the couch itself or the chair, it makes it so good. I mean, it's amazing. People struggle, and they can't get up, and you just tell them those things, and they're like, oh, I can stand up by myself. So just those few little steps will help. You person? Yep. So, and that's written here on the sit to stand sequencing. Move the edge of chair, feet back, nose over ears, and push. This is the other thing that I see happen a lot. Transfers and not being safe, not being easy. So they want to get up from their couch or their chair and they hit it. Okay, you can't get good leverage with both your hands way up here. So if you can convince them, that's the hard part sometimes,
Yeah.
to push with both their hands and then reach up. Or some people will concede to doing this because they want to have a hand on there. Even if they can get one hand here and one hand here, it makes it way easier than here to here. And that again saves you. See, this is all about you doing less work. Because if you do less work, you're less likely to get,
Yeah.
you're less likely to get hurt, really. And the more they do, the better. If somebody's getting up like that, I like to because that you I think it was somebody over said that you just kind of have to be there, right, for balance. Maybe that was you. Will you come sit in the chair for me? Will you be my helper? Okay, so if she's going to get up, and I'm a little worried about how her balance will be when she first stands up, then I usually will just stand at the side, and I want you to stand up. If I'm not using a gateway, which I would be using, but if I'm not, sit back down for a minute. I like to hold on to pants.
Oh, a wedgie.
Just because as they go to stand up, go ahead and stand up, then you can kind of stabilize her. So I'll usually have a hand kind of on the shoulder, one on the back. You don't even have to hold on the pants, you just kind of there. That way, if they're a little off or they need a little bit of help, all you need is a little bit of help, then you can kind of give a little push. Yep. Another thing is a lot of people have a hard time bringing themselves far enough forward, like that little bend forward. So you're kind of lifting them, but all you really need to do sometimes is just kind of push them forward. And if you push them forward, then they can lift. I was working with a lady yesterday who was like that way. She was initially, we're like lifting her, and then but finally I was just like, push her forward. Once I got her where she needed to be, she could stand up. So think about that, just helping them move forward. Yes.
What if they don't have the strength
To stand up.
to stand up or to get up?
So the gait belt, and then you can lift if you need to. You're good body mechanics. You're pulling up and forward. You're kind of up and forward. And again, if you can get them over their feet, a lot of times they have more strength than you think they do.
Like they think.
Or that they think they do.
Yeah.
Mhm. So sometimes it's just a matter of getting them in the right position and then helping. But the gait belt is usually what I use then. I know a lot of caregivers do, I think I called it on here, the granny transfer. I don't know why I called it that, but where you stand in front of them and then move around like that. That's okay. If that's what works for them and that's what they're comfortable with, that's fine. You can block their knees that way. You can give them good support to bring them forward that way. It's just a little less independent than if they're pushing from the chair and doing more of the work. So I don't use that personally because, again, my goal is always independence. But if that's how they're comfortable transferring with you, it's fine as long as you're balanced. You feel okay. If you do that one, I've seen aides in facilities like have the patient put their hands around their neck. Okay, that just like terrifies me because all of a sudden they have a whole lot of control over you because they can pull and that is just, that's dangerous to me. So if you're gonna do that kind of transfer, I would just have them put like maybe their hands on your, just kind of like here, because then you can still, if they're here and they're like, oh, then you're going down. You're going down.
Can I just
Yes,
interject
please.
something? And I guess I'm speaking to the choir, but the great thing about the independence and having them do as much for themselves as they can is that they retain their strengths longer and better. you know, if you have them wash as much as they can, you know, they can do it longer.
Right.
You know, everything they can, and they realize what they can do, you
Right.
know? So,
Eventually it's like empowering.
yeah.
It is, it's kind of
It gives
amazing
them
when
their
you have that
independence
person
back.
who's been stuck and they can't get up and all you do to teach them is just move forward and do this, and then they're like, whoa, like I can totally get out of this chair. It is empowering to them as well. And I love that because that's true. And that's why I try and teach families a lot. There's a lot of families who just come in and they just do, like they just do what they do everything. And I will have to teach them, let them struggle. Let them try because they're never gonna get stronger and they're gonna lose their strength if you don't. So it does take longer. That's the downside of it all. But you know, if you're there for
We're
a
there for a
shift and you're
while,
getting
yeah.
paid by the hour, let them struggle. It really, I mean, that's what I'm usually with the patient for about an hour. And it's what they get is what they get. And it's for me, it's better for them to like walk through the process and get the strength from struggling on trying to get up and down. Usually I make them do it like 10 times in a row, but then to do it for them one time. So a stand pivot is just standing up and pivoting from one place to the other. So you can do it without it's an AD stands for assisted device. You can do it without a walker or you can do it with a walker. And like we said, you know, you can do the one with like a hug transfer. I don't know what you call it. What do you call that? What do you call it when you like put your hands around them? What do you call that? Do you have a name for it?
Bear hug.
What?
Bear hug.
The bear hug. Or if they have a walker and you want to foster a little more independence, again, you can have them just stand to their walker and then just take those little steps around, get back down to their chair or to wherever you're going, to the bed, to the toilet, to whatever surface you're working toward. A squat pivot transfer is used a little bit more for people who are a little lower function. They maybe can't stand all the way. But most people don't do a lot of those. But I kind of showed you here. If you're having them do that kind of transfer, you always want them to reach to the surface they're going toward. That does a couple things. It helps them participate, but it also puts their body, if I reach that way, my bum starts coming up, so it's getting my center of gravity in the direction it needs to be going. The other thing you want to think about is having their feet in the right position. Most of them will have their feet like this. If you try and transfer like this, it's really hard. So if you have them turn their feet before you even start, then you can have them push here, and then it's super easy to give them there. If you're assisting with that kind of transfer, do you want to be my guinea pig? Come sit right here.
Can we move to the walker
Oh,
for
sorry.
the video?
So if I'm going here, and again, I would actually take this out, if we were going that direction, to the chair. And I'd use my gate belt. We're gonna pretend like I'm gate. Again, have them move to the front of the chair if they can. So move forward for me a little bit. Just forward, okay. And then we're gonna get our feet headed in the right direction. And I want you to reach for the chair. And you're gonna push from here. If they can push from the surface they're on, that's always helpful too. And then I'm gonna come right here, and on the count of 3, we're gonna go 1, 2, 3. No, whatever. So you kind of pivot with your feet, don't turn with your back. Okay? Yeah, I had my foot there just to keep it from going a direction I didn't want it to go. You can also block a knee with that. If you see how I'm. That if they have if they've had a stroke or something and their knee won't support them. And you can just block it and it's not gonna go anywhere. Okay. All right, what else do we have on here? Transfer boards we talked about a little bit. Doesn't sound like you use them a ton in your setting. So a dependent transfer. Do you have any people who can't use lifts if they're dependent? Do you ever use lifts in the home? Like Hoyer lifts, Sarah lifts?
Occasionally,
Okay.
occasionally.
You probably don't see a lot of dependent transfers though. like where they
No,
can't help at all.
But if we do have one, we'll have a caregiver come in and train with that.
Okay. Okay, so they chill. Okay, so we won't talk about that. Lifts are kind of cool.
So can you just tell about the bathtub?
Getting them into the bathtub,
Yeah, the
like the benches.
bench, yeah.
What do you want to know about it? How do I?
Well, I've done it before, but I don't know, even know if I did it right.
Okay, so is it a bench that comes outside of the tub
Yeah.
that you're talking about?
Then it-
Yep.
wait a minute.
Yep, so if this were, we'll pretend like this is a bench that's outside of the bathtub. The bathtub's over there. I actually did a transfer with a man right before I came here on his bathtub. So, most of the time those have, well, some of them have backs on them, especially if they hang out over the side. Those are the easiest ones if they hang out over the side. I usually just have people back up to it, sit down, and then lift their legs up over the bathtub and then scoot in. Sometimes they can't scoot very well, so you may have to like get in the tub and kind of help them scoot
Yeah.
over. And that's okay. If they have a handle here, like most, and then they have an armrest, then they can use that armrest to kind of help with the scooting.
And putting a towel down on that.
It'll make it
plastic
easier to
surface
slide.
helps.
Oh, okay.
Yep. Put a towel there, and then once they're sitting, they can kind of, the whole towel moves. Instead of the bum cheeks sticking to the plastic. Yeah. That doesn't feel that good. And then getting out, I just do the opposite, come to the edge, lift up, and turn. Sometimes this is a little harder
Yeah,
because
it
there's
is.
nothing to push from right here. Often there's a back here. If there's a back here, then that's great. Otherwise, I will just help them, you can just help stand up. You're probably not gonna have a belt on them because, they just took a bath. So just
Yeah,
make sure that you're,
Had trouble with her scooting or something.
yeah, so the towel is a perfect thing that should help. I don't know, any
Well-
other suggestions for that if they're,
I like to put towels around my client so they don't feel exposed and they keep their dignity, but it helps them stay warm. They hate
being
because
cold.
they get so cold. So I put a towel here and one over that, because I know I'm gonna be there long enough to wash them and dry them.
Right.
Put them away anyway. But once all those towels are wet from the shower, the bath or whatever, then I'll remove them and put dry ones around them to dry them. And I get them dressed as much as I possibly can while they're right there and put a dry towel down so I can dry their feet really well, put on their shoes and socks. Then they feel secure and they're, they can almost get out of the tub a whole lot
almost
easier.
dressed. Yeah, that's true. I think, if you do it right there, it's less intimidating, I think, to try and transfer when you've got clothes on than when
Yeah.
you don't. So,
Right, right.
and then bed mobility. Do you help people get in and out of bed? Tuck them in at night? So just remember on there, again, something I didn't talk about your safety is when you're moving people, you want to be close to them, okay? So you keep them close to you. If you're trying to help them and you're like lifting from here, you're gonna hurt your back. If you can get, right in by them or right here by them. Same thing with moving in the bed, the closer you can get. I sometimes will put me up on the bed so I can get close enough to them. I've been known to put both my knees in the bed because they were like too far away, that kind of thing. What difficulties do you have with getting them in and out of bed? Any that you've noticed?
It was like the couch. I used to-
Yeah. So same thing, once they're to the side, have them scoot forward. One thing I see is that they'll be too far down in the bed and then like trying to scoot them up in the bed. So to keep that from happening, just make sure they're really high up in the bed when you have them sit down. Like I won't let people sit down until they're where I want them to. Nope, take another step to your left. Nope, another step to your left. And then when they're there, then they can sit down. Getting back in the bed, you know what a bridge is? You know what bridging is? So once they're in the bed, if they're not far enough to the side, you can have them bridge. So you put the legs up like this, they bridge like this, and then they move their bum, and then they can move their feet. And you sometimes have to help with the shoulders, but it's a whole lot easier to move just their shoulders than to try and get them the whole body over. Being down here, but oh, if they can't lift their own hips too, then you can just grab like their pajamas and help lift and then shift where you want them to go.
Sometimes they have slides.
Yes.
And, you know, hold your hands around their ankle.
Yeah.
We use like, sometimes they're laying on a towel or like a pad.
No, in the
Like
hospital.
put their legs up and then you pull the pad over and their body.
No, for real, in the hospital, they actually use draw sheets, is what they call them. They actually put a sheet down so that they can use the sheet to move. Okay, oh yeah. Yeah, as long as you're using good body mechanics when you're doing it.
I'm not leaning over the.
Yeah, you don't want to be like, you know, get as close as you can, get it close to you, that kind of thing. Draw sheets are easier if you have two people, but you can do it by yourself. So. Any other questions about?
I have a really quick one. We are recording this for the caregivers who couldn't come, but we'll be giving them this handout. There are a few shorthand and acronyms.
Sorry, yes.
Do you mind explaining those?
AD stands for assistive device. So it's anything like a walker, a wheelchair, a cane, anything like that. The non-weight bearing and non-WBING weight bearing. So if they've had like a fracture and they can't put weight on that leg. UE is upper extremity. LE is lower extremity, so arm or leg. PM is a pacemaker. And
BLT?
no bending, lifting, or twisting.
Wow.
I think those are the only other ones.
Thank you.
And then I don't know, do you have people who, I mean, hopefully they aren't falling while you're there, because you know, we don't like that. I don't ever like it when people fall when I'm around. Do you know how to help them get off the ground if they do fall while you're there? No, you're not supposed to. Oh, are you not supposed to? Yeah, I don't know what your
There are
rules
some
are.
better ways to do it, right? If they're really wanting to.
If they,
So what are your rules as far as helping, if somebody's on the
In the
ground,
book,
if they
it did
fall?
show you how to do it, but I don't know if we're supposed to.
well, you can help them roll onto their stomach.
Yeah, so
You know, their knees.
if somebody, I'll
Use a
show
chair,
you,
use
and
a
then you
chair,
can
right?
determine what your policy is about doing it. So if somebody falls and they're on the floor, I always tell them if they're bleeding a lot, just call 911, don't even bother, okay? Or if they're in a lot of pain and they think something's wrong, don't bother, just call 911 or push their button or whatever. If they're down and they're like, you know what, I'm okay. And then I'm shocked, I'm nervous, whatever, but I think I'm okay. So after that, then we'll have them roll onto their side and then usually push up into kind of a semi-sitting, and then get on your hands and knees if you can. That is harder than you would think it is for most people, but if they can, if you can't get to there, they can just kind of do a scoot to where they need to, but I always tell them to go to a chair, a couch, a bed, something like this. So they get to where they're going, put your hands up on the surface. Most people have one leg or that's stronger than the other, and they usually know it. It's the stair that they go up the stairs with, or the leg they go up the stairs with. So take strong leg, and they're gonna put the strong leg up, and then they're gonna use their arms and their strong leg to push and just kind of slide onto whatever surface. I don't ever try and have them stand all the way up because that's a long way and people get dizzy again. And so
Most of our seniors don't have that agility.
yeah, and a lot of people don't, they need a little extra help. But some people that I've worked with, if they've fallen and they know that process, they can get up. A lot of them just want to do, you know, they're in the middle of the floor and they're like trying to, they just can't figure out how to get up because it's hard to just stand up. But do you have any?
They're heavy.
Yeah.
You need to call 911.
Yes, yeah, no, don't even try and, because then you're gonna put yourself at risk of getting hurt. Yeah. Any other questions about specific?
I was helping with a client and I was helping her walk from the bathroom into her front room. Her comfort that family was using for her comfort was to have me in front of her holding on and going backwards. And that was not safe to me.
No, that doesn't seem that safe.
No.
Because you're walking backwards, you can't see where you're going. If
Yeah.
you trip and you're holding on to her. I always recommend being at the side of the patient holding onto the gate belt if they feel like they need a little more support. And sometimes that's all it takes. You put a gate belt on them and they're like, oh, I'm safe now. They've got a hold of me. So really, sometimes that's all it takes.
Are you standing on their weak side or their strong side?
Usually their weak side. That's the better side to be on because that side's more likely to give and you're ready to support them. Sometimes with like weird environmental stuff, that's a little hard to do, but
And with this particular client, her daughter has done that with her so
so
long.
she's
And
used
she
to that.
has dementia, so she gets totally confused when you
Do anything
want
different.
to.
So
I just wanted to know how safe or, you know.
It would not be the ideal thing to do in my opinion. But if that's all the patient will do, then you gotta work with what you got.
Just on the right way, gate belt, put your arm around, hold on to it. They want to hold your hand right there.
So will you be my helper again? So if she were my patient and I was trying to walk with her, I would have a gate belt around her, just hold on to the gate belt. And then sometimes they really do want to hold on, so you can just kind of put your weight. And then they feel a little more secure that way.
That would be good for doctors.
Is requested that. Yeah. Any other questions? They could, they could theoretically call. If you're ready, they're probably not going to. I had a patient at the hospital when I was working there. She had a walker. I had her like this. All of a sudden, she just went down. And this is what happened. No, bend your knees, bend your knees. Oh. Sit on my leg, sit on my leg. I just pulled her onto my leg like this. And I stood there for about 5 minutes. It was the longest I've been all my life. Because the door was shut and the call bell was over there. And I was just like calling. I was like, okay, I need help. But I was able to just support her on my knee. I've done that a few times with patients who have lost their balance, gone down, and I just hold them. It's a little exhilarating. I was a little shaky as it was. But if they do go to fall, that is always like that's my reaction. Go onto your knee and they just sit there until they can get their strength. And sometimes you can get them back up. She just was like, she could not move. So, but they could theoretically fall. If you're prepared, you should be able to help them to not like kind of take place. And if you're, hers was just like it was like boom, there was no warning. But most of the time people start kind of wobbling. And if that's the case, you can get closer to them, pull into you, and then it stabilizes them. Or if you're by a wall, lean them against the wall, that kind of thing. So that there's more support. Anything else? Any other questions? I guess I talked longer than I thought I was going to. You did get out early. Well, enjoy your dessert.